So the floor is open for questions. Please.
I have a question about secondary use of the spectrum. That one of the panelists just pointed out that the airline testing frequency is being used on a secondary basis. Usually in these secondary basis systems, the FCC puts really a stringent requirement on sensing. That means that they would say, for instance, if you sense a certain amount of power, you have to be quiet. Is it the same case here?
Ray, I think you have the answer. Yes. Well, interestingly enough, there's very specific parameters around here, right? Because the AMT, the testing sites are very carefully allocated and used. So you have I don't know if it's unique, but it's very close to unique, where you know when the primary users are going to be using the band, what band they're going to be using, and where it's going to be located. It's very unusual. So the sensing isn't going to be, it doesn't have to be that stringent here.
So the FCC requires that all the primary users of the spectrum make a database and give their locations to all of the guys that are building medical devices. Am I understanding it right?
Actually, the primary users already manage their band because they're worried about interference with each other when they test in the band, right? So this organization called AFTRAC already manages the band for the primary users. And for the secondary users, for this medical proposal, there's going to be also a coordinator, which has yet to be selected or really carefully defined. But those two coordinators, AFTRAC and this MBANS coordinator, are going to have to work with each other to carefully manage this to make sure that there's no interference.
So for instance, in TV white spaces or in other bands that the frequency is being shared, usually there's a database that you have to access over the internet and figure out who is transmitting potentially which are the primary users in that area. Or else there are centers that are government-owned, and you know in a radius of them you cannot transmit, you're GPS enabled. Is it a similar thing there?
I guess in some ways, because the expectation is that there will be a database, but it'll be managed by AFTRAC, which they already have, and it'll be managed by the MBANS coordinator. So like a hospital that wanted to use the band would apply to the MBANS coordinator, and then they would give them information back. If they would say either you're within radio line of sight or you're not. And if they're not within radio line of sight, they would just operate.
So suppose that I have a bunch of gadgets hooked up to my body. Are these gadgets, do these gadgets have to access the internet to figure out where they are?
Oh, no.
So how would they know where they are?
Well, keep in mind, right, there's there's one thing I didn't describe in my talk, right? One of the other requirements is that there's a beaconing system put in place in the hospitals.
Uh-huh.
So if these sensors get too far away from the node, they're required to turn themselves off. And that's one way to maintain this requirement that they stay for in-hospital use only in this lower 30 megahertz. So if you, which can happen, right? I mean, I'm sure if you've been in a hospital every once in a while, you've walked out with some of these sensors still taped on you. It happens. The devices will automatically turn themselves off once they're no longer within range of the beacon system inside the hospital. And that's looks like it's going to be a requirement.
Okay, thank you.
A question for the first speaker. I saw one of the bands was 950 megahertz. That you were the 950 megahertz ISM band that you were listed amongst all the other bands there. Isn't that? Does that mean there's going to be some change then to how the 915 is being used to accommodate your new use of the spectrum?
Comply with that ruling.
So what you're essentially saying is that's one that could potentially be used then for your new band then?
Yes.
Okay,
Yeah.
Thanks.
I have a question. So one gentleman talked about the medical body area network, and one talk about the body area network in general.
Can either of you give an example or some examples for body area network that is not medical?
Not medical. Yeah, we had discussed, we have many applications that talked about what we call consumer applications, non-medical, for body area networks. I'm not sure if I answered your question.
If you can give one or two detailed examples.
Well, for example, fireman health monitoring. You know, there's a lot of critical professions in the society where you're pilot on your airplane, where we really worry about their health for a certain amount of time while they're flying. While they're flying you on your plane, you want to make sure that, you know, if you can predict a heart attack within a few hours, which some medical people claim they can do with certain body implanted sensors, then this would be one of the applications.
I think actually he meant application for
Non-medical, but I keep on hearing
but
medical.
this isn't like, you know, therapy. It's simply you want to make sure that they're okay, their maintenance.
So if you want, if I may, you want a hardcore non-medical, I think the gaming application
Yes.
would be one that suggested, like you're wearing glasses and gloves that are communicating with each other. The distinguishing factor is the content of the information that's being communicated. Has it anything to do with the vital signs or the health, or is video or voice between two gadgets that happens to be on your body? So,
I mean, the way we define it is ultimately what's the intended use of that data that's been generated. And it's based on the intended use and whether it falls into one of two categories. At the highest level, a consumer usage case versus a medical usage case that a medical professional would actually drive a decision on that data.
People training in sports. I do have a group of students which I'm very suspicious of. I mentor some PhD thesis students, and they became very intrigued by the possibility of deep brain stimulation in video games. And so I don't even know I want to know what they're experimenting in the lab with, but people will come up with ideas.
So one of the technologies that I think Art mentioned is HBC, that's human body communication. And that is when you touch two devices and the information is conveyed through your body, but the content of information need not be anything medical. So that's another example. Mason.
I have a quick question for Anthony and Arthur, both in terms of standardization and continue the kind of the range of technologies that you consider. All of the communication technologies that have been talked about so far are far field type communications. I'm wondering if you consider near field communication. There is this NFC consortium that is gaining a lot of momentum in payment systems. I'm wondering, because it does make sense in human body to use near field communication, is it being considered, or is it still limited to more of a far field type transmission?
Well, it wasn't one of the 30 proposals brought to the thing, so currently we're not considering NFC.
Continuous had proposals come to it that have NFC technology on the PAN side, the personal area network side. And we continue to work through those, along with other transports as well. But for the moment, the three that we highlighted today, that being Bluetooth, Zigbee, and USB, are the current standards that we're leveraging.
Like Bluetooth. Do we have any example of that sort in the body area network standardization? Means that somebody has developed a technology like Bluetooth and comes to 802.15 and asked for like this to become a standard. Or somebody like NCR has done the direct sequence spread spectrum, comes to 802.11, says why not we make it a standard?
I would have to go review all the 30 proposals, but I don't believe anybody brought any existing thing they have. They may have. We don't ask that at IEEE. an individual brings a proposal and that's it. We don't know if they've used it or not used it. The only thing we ask that the IP be available public and either released to IEEE and available to users on NRAN basis, which means non-discriminatory and reasonable license rates, like in 802.11, that case.
In 4J, we've only heard preliminary proposals, but so far no one has brought anything that exists, but we'll be hearing final proposals, so it's a possibility, but it hasn't happened yet.
I'm hearing discussions about sensor standards, the medical device standards, the measurement system standards, the hub standards, and so forth. Where does the antenna fit into this? Is it considered to be embedded as part of a component or system? And the reason I ask is, for instance, on Bluetooth and some of the applications that we tried to do in an operational scenario, if the Bluetooth for distributed sensors on the body, if the device is on the front of the body and your hub and node is on the back, you have dropouts. And how do you consider dealing with those kinds of elements?
Well, in our case, we did require presenters to include antenna as part of their PHY proposal, specifically in the body-centric application. I don't know if you're doing it right.
That's a great question and a great answer, but it was outside the scope of our original proposal. But as we engage more with body area network ecosystems, I would see that coming into the fold, but it's not in our scope today.
Yeah, because particularly when you think about distributed, as technology miniaturizes, you're starting to have self-contained systems where the sensor and its whole communication element is all a self-contained device, and you may be subjecting yourself to artifacts and other kinds of considerations if you don't include that as part of some of the considerations.
Yes.
I think there was a question this morning about liability issues, and they came up during one of the presentations, and I think Nat mentioned that you will talk about it this afternoon. So if you could quickly mention that, I really appreciate that, because I thought that's a very, very important
2 minutes.
subject.
Yes, right. Well, add it to my 2 minutes. So this is a great point. And let me step back to maybe 200,000 foot level. If you look at the FAA and compare it to the FDA, the FDA has no right to come into a hospital and say, I want to see your procedures or your rationale for why you think a certain practice is safe, which could include data coming across unreliable networks for medical decision making. The FAA, on the other hand, could walk into Cape Air's offices and ask to see the policies and procedures for crew fatigue, and they could make a ruling on it. So I want to discuss the concept of these two recent initiatives in which the FDA is involved with hospitals as perhaps a salutary attempt to help us resolve the imperfectness of technology by allocating responsibility to certain people for deciding that it's okay to do something. The first one we cited was the IEC, somebody help me if I get acronyms wrong, IEC 80,001 rule. The second one, which was released February 14th of 2011, was an FDA guidance with respect to something called MDDS, Medical Device Data Systems. Not to go into too much detail about it, but I think a way to think about this is that the FDA is finding actually an excellent avenue into getting inside the thinking or the safety assurance cases that healthcare organizations have to set up for themselves when they are moving data across complex networks which are not end-to-end controlled proprietary aspects. So to make a more realistic, in summary, to make a particular realistic example, if I was a healthcare provider in the center of Australia and I have cancer patients in terrible pain with infusion pumps at home, I could make a decision under, say, 80,001 or its equivalent, that it's okay to send an instruction to an infusion pump to increase the pain dose for a patient who's in terminal cancer, even though there is a statistical possibility that the cellular network or the other aspects I can't control of the communication network are imperfect. And so I think I'm going to stop there, but I think oftentimes we come to meetings like this and every company that has a product is wrestling with the issue of how do I achieve perfect reliability end to end when I'm not controlling the whole thing anymore. And I think that an answer, of course we can always try for perfection, but an answer is to embrace the providers in some joint responsibility for everybody accepting that it can't be perfect all the time, but that something is better than nothing in terms of remote communication, for examples like the one that I gave. Stop there. 2.5, no, 2.75 minutes.
That's a critical point.
By thanking our panelists for their insightful presentation and accepting our invitation to be here. I also like to thank Kaveh and his excellent team of students for arranging this meeting, and we really look forward to keep the ball rolling.
Thank you so much.